Certain rheumatic diseases are associated with specific human leukocyte antigen HLA alleles. Here are some notable associations. 1. Ankylosing spondylitis AS, strongly associated with HLA B27. Over 90% of AS patients carry this allele. 2. Rheumatoid arthritis RA, associated with HLR4, especially the HLA-DR1B4 allele, and to some extent with HLA-DR1. 3. Psoriatic arthritis A, also associated with HLA-B27, especially in those with axial involvement, and HLW6, which is linked to both psoriasis and PSA. 4. Reactive arthritis, strong association with HLA-B27, particularly after infections. 5. Systemic lupus erythematosus SLE, associated with HLA-DR2 and HLA-DR3, particularly in certain ethnic populations. 6. Type 1 diabetes T1DM, frequently associated with HLA-DR3 and HLA-DR4. 7. Juvenile idiopathic arthritis JIA. Various subtypes are associated with HLA-DR8, HLA-DR5, and HLA-B27, especially for enthesitis-related arthritis. 8. Celiac disease, strongly associated with HLA-DQ2 and HLA-DQ8. 9. Sjogren's syndrome, often associated with HLA-DR3 and HLA-DQ2. These HLA associations help in understanding the genetic predisposition and pathogenesis of various rheumatic diseases. Here are additional HLA associations with other rheumatic diseases. 10. Dermatomyositis DM, associated with HLA-DR3 and HLA-DR8 in adult forms of the disease. In juvenile dermatomyositis, there is a weaker association with HLA-DRB1 alleles. 11. Polymyositis PM, linked to HLA-DR3 and HLA-DR52, particularly in those with antisynthetase syndrome and interstitial lung disease. 12. Mixed connective tissue disease, MCTD, strongly associated with HLA-DR4 and HLA-DR1. 13. Scleroderma systemic sclerosis. Diffuse systemic sclerosis is associated with HLA-DR5 and HLA-DQB1. Limited systemic sclerosis, CREST syndrome, is often linked to HLA-DQA1 and HLA-DR1. 14. Behçet's disease, strong association with HLA-B51, particularly in populations from the Mediterranean and Middle East regions. 15. Granulomatosis with polyangiitis, GPA, formerly Wegener's granulomatosis, linked to HLA-DPB1, especially the allele HLA-DPB10401 in white populations. 16. Takayasu's arteritis, associated with HLA-B52 in certain ethnic groups, especially East Asians. 17. Polymyalgia rheumatica PMR, linked with HLA-DR4, particularly in individuals with giant cell arteritis, GCA. 18. Relapsing polychondritis has some association with HLA-DR4, although this link is weaker than in other conditions. 19. Antiphospholipid syndrome, APS, associated with HLA-DR4 and HLA-DR7 in various populations, though these associations are not as strong as in other autoimmune diseases. These HLA associations help guide genetic research, risk assessment, and understanding the underlying immune mechanisms in various rheumatic diseases. The association between HLA-B27 and ankylosing spondylitis, AS, varies significantly across different ethnic and geographic populations. While HLA-B27 is strongly associated with AS globally, the prevalence of this allele, as well as its strength of association with AS, can differ based on regional and ethnic backgrounds. Global variations in HLA-B27 and AS. 1. Caucasian populations. In Western populations, such as those in Europe and North America, over 90% of AS patients are HLA-B27 positive. The allele is present in around 6 to 8% of the general population, making it a strong risk factor for AS in these regions. 2. Asian populations. In East Asian populations, e.g. China and Japan, the prevalence of HLA-B27 is lower in the general population, 4 to 6%, and while still strongly associated with AS, the percentage of HLA-B27 positivity in AS patients can be slightly lower, around 80 to 90%. In South Asian countries like India, the prevalence of HLA-B27 in AS patients is also high, but may vary across different regions. 3. Indigenous populations. Some indigenous populations in North America, e.g. Haida and Yakima, have very high frequencies of HLA-B, and the prevalence of AS is correspondingly higher in these groups. Middle East and Arab populations. In the Middle East, the association between HLA B2710 and AS appears to be weaker compared to Western populations. Studies from countries such as Egypt, Saudi Arabia, and Jordan have shown that the prevalence of HLA B27 among AS patients can be lower than what is typically observed in Europe or North America. Several factors contribute to this variation. 1. Lower prevalence of HLA B27 in the general population. In many Middle Eastern populations, the overall prevalence of HLA B27 is lower. For example, in certain Arab populations, it has been reported that HLA B27 is present in only about 1 to 3% of the general population, which may explain the weaker association with AS. 2. Genetic and environmental factors. It is suggested that in these regions, environmental or other genetic factors may contribute more significantly to AS susceptibility. For instance, infections, lifestyle factors, and possibly other HLA or non-HLA genetic factors might play a more prominent role. 3. Other HLA subtypes. There may be other HLA subtypes in Middle Eastern populations that contribute to AS. Studies have indicated that specific HLA-27 subtypes, such as HLE-2705, HLA-B2702, and HLA-B22704, might have varying degrees of association with AS, and some of these subtypes might be less common in Middle Eastern populations. 4. Variations in disease presentation. In some Middle Eastern studies, AS may present differently, with a milder course or varying symptomatology, which could contribute to the observed differences in HLA-B27 associations. Conclusion. In Middle Eastern populations, the association between HLA-B27 and AS is generally weaker than in Western or East Asian populations. This reflects the complex interplay between genetics, environment, and disease expression across different ethnic and geographic groups. While HLA-B27 remains an important marker, other genetic and non-genetic factors may have a more prominent role in AS in these populations.